Hello and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. And today is March 14th, 2018, and you're here with us for our UNC Cancer Network RN and Allied Health Telehealth Lecture. So a few preliminaries and then we'll get started with our presenters. First off, I want to let you know that if you are having any technical difficulties at all, please let us know right away. Don't wait 20, 30 minutes and hope it will work out. Everything should be working perfectly, so if there's a technical issue, call us, 919-445-1000. We have a team standing by to help you with any technical issues that may occur. We're going to use Poll Everywhere. I'll talk about that in a moment. You can always find us on the web at unccn.org. We're on Facebook, we're on Twitter, we're on YouTube. Lots of places to find out all sorts of information, and we'll talk a little bit more about what's on there at the very end. But it does include over 200 telehealth lectures that have been recorded over the last several years. Okay, if you are using MediaSite, if you're one of our MediaSite users and are using that link, I just want to remind you that you have lots of choices with that MediaSite live stream. You can go ahead and use this box here to have the both the slides and the video overlap. If you click on this next box down, you can see them side to side like this. If you just want to see either our faces or just the slides, you can click this here. And then to swap up what you're seeing to make the slides bigger, the video smaller, or vice versa, you can just click these two little arrows, and that'll swap that out. We always want to make sure our MediaSite users know that they have all of those different choices. We're going to use Poll Everywhere, both for a question right at the very beginning, and then this is where you'll share your questions with Dr. Yopp and Dr. Rosenstein at the end of the presentation. So to get started, most of our folks using Poll Everywhere just use any phone that has texting capabilities. So in the to field, you'll type 22333, and in the message field, you'll put in the letters UNCCN. You only have to do that one single time for today's presentation. You'll get a little message back. It will say joined, then you're joined for the rest of the lecture. We do have a browser option as well. If you go to pollev.com/UNCCN. We did just have a site that joined us and is not muted. Could be one of our rec sites, not positive, but if you just joined us, if you would be sure to mute. Thank you so much. All right, so Poll Everywhere again, 22333, and then the letters UNCCN, that'll get you in if you are having any difficulty with that. 919-445-1000, you can talk to our team and they'll help you out with that. We are going to start off with a poll. Which of the following stages of grief was not outlined in Elizabeth Kubler-Ross's 1969 book on death and dying, what the dying have to teach doctors, nurses, and clergy and their own families? So which of the following, I think many of you are probably familiar in some way, shape, or form with this book and the stages of grief that Elizabeth Kubler-Ross had listed. Which of the following was not in there? Is that A, denial, B, anger, C, bargaining, D, acceptance, or E, anxiety? If you know the answer, that's great. Go ahead and just text that once you've joined Poll Everywhere. This is anonymous, so if you're not sure, still go ahead and make a guess, and we'll see what you've got there. And we still have one site just came in, didn't mute. Oh, no, still didn't mute. So remember,
they can't hear anything.
Sites, please be sure to mute. There we go. We got it. Thanks. All right. With that said, I want to go ahead and welcome our presenters. Dr. Justin Yopp, welcome.
Thank you.
Dr. Don Rosenstein, welcome.
Thanks, Tim.
Great to have you both here. A little bit about each of you. Dr. Rosenstein is director of the UNC Comprehensive Cancer Support Program with joint appointments in the departments of psychiatry and medicine. He also serves as vice chair of the Division of Hospital Psychiatry and is the past president of both the Academy of Psychosomatic Medicine and the American Psychosocial Oncology Society. Did I get that all right?
That's right.
Okay, great. And Dr. Yopp is a clinical psychologist and the associate professor in the Department of Psychiatry at UNC. He is a member of the UNC Comprehensive Cancer Support Program at the North Carolina Cancer Hospital, where he provides inpatient as well as outpatient and therapeutic services. He also works with children whose parents have serious medical illnesses such as cancer. On target?
Yeah.
Okay.
Thank you very
good.
much.
Thank you both. All right, so let's take a look and see how our folks in our poll did. Okay, I see a trend here. You guys want to give it to them?
I think it's what we predicted, right?
Absolutely.
Yeah.
It's very well understood throughout society. So the right answer is anxiety. That should be depression. But we'll talk more about the Kubler-Ross model in just a few minutes.
Okay, well that's impressive that our audience really for the most part had that. Leave that up for just a few more seconds, but I think it looks like everyone who had wanted an opportunity to respond has. Just to remind you, now's the time to be starting to, as we move forward, think about your questions and you can, in the same way that you put in an A or a B or a C earlier, at the end of our presentation, you'll be able to type in your full questions for Dr. Rosenstein and Dr. Yopp. And without further ado, improving end-of-life care, what we can learn from the bereaved. So we're really looking forward to this presentation. I'll turn it over to both of you.
Thanks so much, Tim. So Justin and I are very excited about having an opportunity to talk with you about a body of work that's really developed over the last 8 or 9 years. And it's a story that we're excited about for all sorts of reasons. And one of the main points we want to make today is that this is a patient and family-centered care story. And I hope, will stimulate lots of associations in your own minds about how we can partner in better ways with patients and their loved ones to improve the kind of care we provide for people who are living with advanced disease and dying from advanced disease. So the way we're going to do this, first I have to kind of just mention one of our disclosures. So I'm doing the slides here. So this work, not all of it, but a good part of this work resulted in a book that Justin and I wrote called The Group, 7 Widowed Fathers Reimagine Life. It was published just a few months ago by Oxford University Press. And so there are royalties that perhaps one day will come our way. Justin and I have committed to taking all the royalties from this book and reinvesting them in our widowed parent program. And we've included the website here where we provide resources for widowed parents, men and women, and we have a research survey that's housed on that site. And so we're doing ongoing collection of data that we also will inform future care. So that's our main disclosure. We're not going to talk about the book, but a lot of the work that we are going to talk about kind of led to the book, and I'll just mention that a little bit later. So here's what we have in mind for the next kind of 40 minutes, and we're going to work hard to leave time for questions because I hope that you'll find this interesting and kind of trigger some questions in your own mind. So I'm going to lead off, and I'm going to talk for 15 or 20 minutes about how we got into this in the first place, just a history of the Widowed Fathers Project. Then I'm going to turn it over to Justin, who's going to talk about some research findings from an online survey that we've had, and then kind of where we're going next in the research. And then what we hope will happen is at the end, we can have a bit of a conversation about both participatory and collaborative research and how that may inform end-of-life care, because that's really the main message of this work, which is that, to put it simply, I think we've got a major lost opportunity for those of us who work in healthcare. And what happens is when people lose a loved one, they leave the hospital and very often don't come back to the hospital. It's the last place in the world they want to go. And these were individuals who were eyewitnesses to how their loved ones lived with cancer or some other illness and then died from that illness. And that's a wealth of lived experience that we don't tap into. And so one of the core themes of our work is to try to instill a feedback loop from talking with people after the fact and essentially ask them in various ways, what did we get right? What could we do better? What was your experience? How did it look from your point of view? So that's the meta message of all of this work. Okay, so here are the specific objectives, the learning objectives for the next few minutes. The first is to kind of, if you've never heard about the dual process model of coping and bereavement, we want to tell you about that and specifically contrast it with the Kubler-Ross model, which is one example of a staged model of grief and bereavement. Then the second is we want to give you some examples from our research about what some of the common main psychological challenges are that are experienced by widowed fathers, and then finally kind of list and talk about several areas of end-of-life care for parents that we think can be improved as a result of what we've learned from talking with fathers and also mothers who have kind of unfortunately lost someone that they're co-parenting with. But just to set the stage a little bit, what I'd like to do is just share 3 preoccupations that I've had for the last several years. And the first is working in a cancer hospital. I don't think I'll shock anyone by kind of speaking an uncomfortable truth, and that is that I think on a daily basis we fail dying patients. Anyone who has worked in modern healthcare settings will know that we sometimes get it right, but we often kind of can do better with how people are cared for at the end of life and how we identify their wishes and preferences and make sure that we deliver on those. And one, I think, particularly compelling example of that is what happens when we're caring for parents of younger children, because it's a particularly compelling case. And so our work with families really, we hope, is going to lead to some insights that will help us understand end-of-life care more generally. I think if we can get this right, or at least better, in the care of terminally ill parents, then I think that we can get it right and better for anyone who's dying. And then finally, as I mentioned earlier, I think that the bereaved as a class of people who have a lot of feelings and thoughts and experiences are kind of a neglected source of information that most healthcare providers ought to tap into. If you listening are interested in this topic and have not yet read Being Mortal, it's a brilliant book by Atul Gawande. It was published in 2014, called Being Mortal, and and is, I think, one of the most compelling treatments of how we deal with death, at least in the United States. And one quote kind of stood out for me that just underscores what I've already said, which is, the experiment of making mortality a medical experience is just decades old. It is young, and the evidence is that it is failing. And I think that in Being Mortal, Gawande kind of lays out a kind of compelling case for the medicalization of dying and how that's really not a long-standing phenomenon, and it's kind of really shifted just in the last couple of generations. We're going to talk about one particular slice of this and really focus on the Widowed Fathers Project. It's a project that was started by Justin and I about 8 years ago, and my part is just to tell you briefly how we got there. And so this was the index case. We have a weekly case conference where we talk about ongoing clinical cases that we have in the cancer support program here at UNC in Chapel Hill. And Justin came in one Wednesday and basically reported on the death of a 42-year-old married mother of 2. She had had advanced lung cancer, and in the course of caring for her, Justin got to know the patient's husband and their children, and he just kind of reported to us that she had passed, and then commented that the husband was really having a terrible time. He was really lost at sea, struggling in a profound way, and wanted to do something for this dad. And we tried to get him to a support group, and there are certainly lots of bereavement support groups that are very helpful, but he didn't feel that it quite kind of fit for him, because a lot of bereavement support groups are for older bereaved, and there may be even some single parent support groups, but those are often for divorced parents, not for people who still have a kind of picture of their loved one that's up by the side of their bed. And so we initially had this idea of starting a support group, and I'll tell you about that in just a moment after a side trip. And one of our initial ideas was we initially wanted to help the kids by helping their dads. We knew that early parental loss is a big deal and has long-lasting effects on a lot of people. And so, one thought was if we could help the dads kind of cope with what they were dealing with, we would secondarily help the kids. Now, over the course of this whole project, we realized that kind of focus on the dads or moms now in and of themselves is kind of, a worthwhile goal, and as is helping their kids. But this is kind of the story of how we got there. Obviously, kind of any death can be tragic. We feel like the death of a mother with young children is particularly compelling. This is a kind of an old picture from Edvard Munch entitled The Dead Mother from 1900. And this was in some ways kind of a precursor to the much more famous Scream by Munch. And part of our hope was that kind of by attending to the needs of the bereaved early, we might be able to prevent kind of the picture that you're looking at on your right. And Justin and I really didn't start this work as experts on death and dying and bereavement. And what we kind of knew was what a lot of you already know from that initial survey that we did, and that was work that was done really back in 1969 by Elizabeth Kubler-Ross. And I won't go into the details here, but this was really a major cultural shift for people in the United States. And she did a tremendous service by bringing attention and starting a national conversation about talking about death and dying. And her work, she was a psychiatrist at the University of Chicago, and her work was based on working with people who were anticipating their own deaths. And it led to the publication of this book, which kind of very quickly became a bestseller and obviously infiltrated itself into the consciousness of the United States. And her notion was, in talking with patients, and her book was based on interviews with roughly 250 people who had advanced illness, mostly cancer. And what she described was a version of a prior kind of model of thinking about bereavement, which was a stage model, that people go through a series of stages. In her work, she talked about denial of death, and then anger at the fact that you were going to die, and then bargaining in some ways. Well, if I can only stay alive long enough to see my kids graduate from high school, and then a sense of depression, and then acceptance. And there was some interesting and compelling clinical work that kind of talked about this. But what was interesting about this is that her work was with people who were contemplating their own deaths. And in fact, what happens after someone dies and how we grieve may or may not have anything to do with how we anticipate our own deaths. And so the notion that these 5 stages in order were relevant for how a husband might grieve his wife, how a father might respond as a single father, how a child might respond grieving their parents. There really wasn't a lot of data for this. And there have been a few studies over the years, and there was a group led by Holly Prigerson when she was at the Dana-Farber. She's now at Yale, I believe. And there have been a couple of studies that have tried to have a data-driven approach, and do we in fact have stages that people go through in order and kind of in a universal way. And what I can tell you is that these studies, and I won't belabor this because of time, but these are more data from this. There are 2 punchlines from this. Number one is that there is some suggestion that there are some broad stages that they were identified that people go through, but it's not universal. It's not overwhelmingly kind of compelling from a data point of view. And there were some limitations, methodological limitations with this as well. And Justin and I, in our readings over the last 8 years, we've kind of gone deep on the whole grief and bereavement literature. And we actually don't think that this is the model that resonates with most people and is consistent with most clinicians' experiences. And in fact, there are some other more modern people who have studied grief. There's one investigator at Columbia University in New York named Bonanno, who has a whole different take on this, and he talks about different trajectories of grief. And in fact, one of the things that is important from his work is that most people actually do well and kind of recover and have a healthy response to grief and don't have a delayed grief. However, it's also worth pointing out that his work focused on people who were grieving, but not necessarily parents who were grieving. And so our work has been focused more on fathers and now mothers who are grieving a co-parent and have children at home. And what we wanted to do is just take a moment to talk about the model of grief and bereavement that we find most compelling. And this is a work that was done by two psychologists in the Netherlands, first published in 1999. And it's called the dual process model of coping and bereavement. And Strobe and Schutt were the ones who first published this. And this captures a much more dynamic way to think about response to any kind of substantial loss. And to make a complicated model overly simplistic, the basic idea is that people oscillate between two different kinds of psychological tasks or challenges. And what they described were loss-oriented stresses and restoration-oriented stresses, and they're really just what they sound like. So loss-oriented stresses are things that are focused on looking backwards, things that you had and lost. This is the more classic notion of grief work, painful memories, letting go of things, kind of thinking about what you had that you no longer had, thinking about the person, thinking about your intact family. And that those are contrasted with the challenges that don't stop just because someone has died. That you have to get up in the morning and get your kids dressed into school, and you have to go to work, and there are new relationships and new challenges, new roles that you have, and essentially moving on. And what they described is that you don't move from one stage to the next when you're grieving. What you do is you kind of bounce back and forth between focusing your attention on what was lost and focusing your attention on what happens, and actually from time to time pushing the pause button, because nobody can be preoccupied with all of this grief work or adaptation work all the time. And so sometimes you just have to, watch a ball game or go to a movie or, go for a run and not think about any of this. But what essentially happens is that over time, people oscillate between these two sets of challenges, and that it attenuates. And that can be quite variable for some people. They may go through this and it gets better over the course of weeks and months. And other people, it may take months and years. The critical factor here with this model is that healthy adaptation to loss involves attending to both sets of tasks, that you can't get stuck in one or the other. And we see that a lot. And so this is kind of a model that when we talk about this with people that we work with who are grieving, this resonates with folks. It feels more natural, more dynamic. And what we hear from a lot of folks is, it's been a year and a half and I still get angry, and I'm supposed to be through that stage by now. And this model doesn't imply that you have to be done with kind of some stage at some point. Okay. So we decided to start this support group, and I'm going to tell you just a little bit about this and then turn it over to Justin in a moment. And this is kind of the classic idea. Here's a New Yorker cartoon of the dad support group, and they're at a bar, and they've got their kids in kind of carry-ons, and they're drinking beer. And in fact, this is what our support group looked like. And it's and if you think that men can't get in touch with their feelings and share their feelings, I'm here to tell you that you're wrong about that. These guys cried together. They shared some of their most vulnerable moments together. They got real. And if you could have witnessed this, it was really quite impressive. And there is something very magical that happens when people get together in a room and they kind of are authentic with each other. We didn't have flowers. We didn't have tablecloths. We kind of got subs or pizza and threw it on the table. And these guys got to work. And we met with them kind of once a month in what was supposed to be a short-term group. Over the course of 6 months or so, we ended up meeting with this group of guys for 4 years. And in fact, they encouraged us at some point to write a book, which is what we did. The initial themes from this group kind of could be categorized in broad bins. And so the first is that this was a unique experience. These were men without peers. They met with a lot of people who really didn't get it, and when they got together, they felt like the other men in the group understood them. They kind of were in the same awful boat and trying to row together. We heard a lot of longing for not just their partner in life, but their partner in parenting. That what we heard from a lot of men is they would kind of get their kids to bed and go upstairs and then have some kind of struggle and want to turn to their wives and basically say, how are we going to deal with this? And they didn't have that, obviously. There was a lot of worry about their kids. The men felt overwhelmed initially, and they really didn't want to screw them up further. They were all worried about the kids because they all lost their mom, and they knew that that was a big deal. And they wanted to get it right, and they were trying to be mom and dad, and it was kind of overwhelming for them. They were struggling with how comforting to be and how disciplined to be, and they didn't feel like they could be a lot of fun because they were exhausted all the time. And then these first 3 bullets were things that they were struggling with from the moment of the death of their wives, and often beforehand when their wives were quite ill. And then in time, this 4th bullet, kind of the moving on, the adaptation, the kind of restoration-oriented stressors. How long do they keep their ring on, their wedding band on? When should they start dating again? These were the things that we heard from these men. And then importantly, they shared with us a lot of insights from watching how their wives lived with cancer and died from cancer. And one of the things we heard over and over again, and Justin will kind of get to this with future directions for our research, what we heard over and over again from these guys was how much room for improvement there was with end-of-life care. And we were some of the first people who ever asked them about some of those questions. So now what I'd like to do is, this is my last slide before I turn it over to Justin, but I wanted to take a giant step back and just kind of talk about this programmatically. So the Comprehensive Cancer Support Program, the CCSP, started in 2009, so we've only been at this for a decade. And not too long after that is when Justin and I started the Single Fathers Due to Cancer program. That's the up in your upper left-hand corner, the SFDTC. And we, when Lisa Park joined us, another clinician, a psychiatrist, a couple of years later, she got involved with a lot of the research aspects of this work. And because of what I was just talking about, these reflections by these men about room for improvement with end-of-life care, Lisa's work has been in looking at the supportive care needs of parents with advanced cancer, kind of the before picture. What can we do to make things better? And her work has continued with several career development awards and ongoing work right now. But one of the aspects of this work that has been most meaningful to Justin and me has been the partnership that we've had with these men. And you can see down below the timeline that we've had a series of partnerships with them. We asked the men if they would be willing to talk to oncologists and present in our Schwartz rounds at the hospital. Every time we wrote a manuscript related to this work, we had them review it, and they gave us great input on this. We built a website initially called widowedfathersduetocancer.org. That's now, as you can see in the upper right-hand corner, widowedparent.org, so it addresses not just widowed fathers, but widowed mothers, and has a new survey. They helped us make an educational video called If I Shall Not Return that you can see on that website. And they have been very generous with their time in doing interviews, teaching medical students, participating in this book. And it's just been a great example of patient and family-centered care where it's kind of been a great opportunity for us to learn from these men and figure out how we can do our work a little bit better. So that's kind of the backdrop, how we got there. I think I stayed within my time. So Justin, kind of you're up next, and maybe you can share some of what we've learned from our research and clinical work with these men.
Great. Thanks, Don. So So Don he showed that one picture of us with the 7 men, and when we started this out, we, as Don said, really got to know these men, became big fans of them and big admirers of them, and thought that what they were doing and how they were grieving and helping their children was really special, and what they offered to each other in a support group was unique and needed and valued, and so much that we wrote a book about it. But we realized that certainly not every father has that opportunity. In fact, as far as we can tell, there were not any other support groups like this anywhere. And so what we decided, as we saw the benefit of the support group and as we saw the challenges that these men face, is that we wanted to reach more of them. And we wanted to learn more, right? We knew these 7 guys really well. But these were just 7 guys. We certainly didn't know anything beyond that, and maybe what we had learned from these men wasn't, maybe we hadn't or couldn't have learned all that there would be to learn. So with those 2 thoughts in mind, I wanted to reach more people and learn more about the experiences of widowed fathers. We developed and launched a website with 2 rationales. The first one being to reach widowed fathers out there, whether they live locally here in North Carolina or anywhere in the country or the world, and to have an online home for these men that they can visit, that they could see the videos we developed, they could see some of the insights that we had learned and was sharing from the men, that they could feel like maybe they belonged a little bit. Because feeling isolated and lost were really big things for these men, that we hope the website would offer some comfort in that way. And the other reason why we wanted to launch it is to house a survey on that, a research survey that we developed here at UNC that was approved by the ethics board, and that has been we put up on the website. So men who visited, this is the former website, singlefathersduetocancer.org, they could surf around the website and get the support and learn about some resources, and they could also click on this button right here if they were interested, and as we tried to put that in green so men would see it, and ask them to take the survey. And so that's what I'm going to talk a little bit about here with some of the survey data that we got from these men. And over the course of the couple years that we had this open, we had over 425, I think 428 men total complete the survey, which was by far the largest database for these men anywhere. So here's real quick the inclusion criteria to be involved in the study. Had to be a father with 1 child, at least under the age of 18, who was still living at home, and the child's mother had to have died from cancer. The father did not need to be married to the mother at the time, but we only had a small handful, I think 6 fathers who were not married. So in our data analysis, we only included the fathers who were married to the child's mother at the time. The domains we assessed really kind of fell into 2 different categories. One, end-of-life variables, which is really kind of what we're talking about today, and that is really getting the father's insights and the father's views on what happened leading up to the time of their wife's death, and with the whole goal of us wanting to know more about that so that we could improve care and that we could offer recommendations to physicians and nurses and really hospice workers, anyone that takes care of these families, to kind of get the experience of the bereaved father following the death, kind of let us know what that was like for them and hopefully learn how we could do better. And the other big bucket was learning about how the fathers are doing themselves, right? How are they doing in terms of their own grief, depression? How did they feel they were doing as parents? And we developed a whole list of questions that we wanted to get to know, that we wanted to ask so we could get to know about the experiences of these men. So you see there, it says baseline and follow-up surveys. So what we did was the first time a father would fill out the survey, that was considered baseline. And if the father filled out the survey within 2 years of his wife's death, then we would, and if the father agreed to it, then we would ask him to fill out a survey every 6 months until we reached the point of 2 years following his wife's death. So we really wanted to get that follow-up data for those men who had lost their spouses more recently. We asked both quantitative and qualitative questions, a lot of kind of multiple choice, and then a couple of open-ended questions that we felt like we got some pretty valuable data from the men on that. You see there kind of some of the instruments that we use. Some of them were validated, and some of those we had to create on our own because there was not a whole lot out there to look at widowed parents, parenting self-efficacy, or other issues related to that. So we used standardized measures when we could, and had to develop other questions when we could not. So real quick, there are some methodological limitations to doing online research. Even though this is becoming a more widely used and more accepted way of conducting research, there still are limitations, and you see a few up there. With probably the most important being that the potential for self-selection bias, that people who would complete this survey may not represent may not kind of show a representative sample of widowed fathers at large. It may have been men who were more willing to visit the website in the first place, or maybe then men who were willing to complete the survey don't represent every father. So that is certainly a limitation, and we could not ensure that the people filling out the surveys were actually fathers themselves, although we couldn't imagine someone would spend 25 or 30 minutes doing that if that was not their situation. All right, so real quick, you see there, of the 428 men, the average age was 46. We had a fairly homogeneous sample. There was mostly white fathers, most of them college graduates who had a job and had at least a decent income. So that's another kind of drawback, is that we don't feel like we tapped into kind of a wide array of these men, but that's what we got. And you see there, 83% of them were not currently in a relationship at the time they've completed the study. So real quick, just some baseline or just some findings about how the fathers were doing, and then I'll get into what they informed us about end-of-life care. So we were pleased, I think, to find, and maybe a little surprised to find, that most fathers reported that they were meeting their expectations of parenting. Most of them, in one way or another, communicated that they felt like they were doing a pretty good job parenting their children. But that came at a cost, is how we interpret the data, because they also reported very high levels of stress related to their parenting. They reported elevated depression. And as you'll see in this next slide, that's not just immediately following their wife's death, but that continued for the 2 years that we would look at these men. So you see there the level, or the graph, the higher the data point, the more intense the depression was. So you see there, over the 2 years, it does get better. But you see that red line, the dotted red line, that is kind of what we use on this measure as the kind of cutoff point. Anyone reporting above that meets a certain threshold for depression. Anyone below does not. And so you see, even after 2 years, even though the depression scores went down, the average still stayed above that threshold. So that kind of really went along with what we were seeing with the men in our group. And the other one there is elevated grief, and this shows a similar pattern, that compared to immediately following the wife's death, compared to 2 years out, the intensity and the frequency of the grief symptoms did attenuate, but I can tell you, compared to other samples that we compared against using this measure, those levels remained high. So the men reported doing pretty well, they felt like, with their parenting, but it came at a cost to them. But more to the point of kind of this presentation is, what can we learn from these men about end-of-life care, specifically as it relates to parents who have advanced illnesses. And one of the first questions we wanted to know about was to ask the men their view of their wives being mothers and having young children. Did that affect or impact their treatment choices? And as you might imagine, it did. And as you might imagine, they felt like their wives being mothers was related to them choosing more aggressive care. And we saw that in the men reported that about 2/3 of the time, that the fact that their wives were mothers and young children led to them pursuing aggressive care, presumably in the hopes for cure. We also want to know whether or not they felt that the physicians were being upfront with them about whether or not their wives are going to die. And as you see here, this is by and large, I think pretty good news. You see there about 65% of the men reported that their doctors did tell the both of them that they're going to die, and most of the other responses were that they told the father but not the mother, and those may have been in cases when the mother was maybe cognitively compromised or not in a position to be told. But only, I think 13% of the fathers reported that they were not told at any point that their wives were going to die. And in some ways, that's still too high. And in other ways, that means the vast majority of them did feel like they were being told. All right. We asked the fathers, was your wife worried about the strain on the children at the end of her life? And you can imagine what the results would be here, and it's certainly what we found. If you combine the very true and mostly true categories, over 90% of the fathers reported that their wives were very worried about the strain on their children at the end of life, which really just underscores what Don and I and others see in our clinical practice, and that's that being a mother or being a father, if you're a man with advanced illness, the fact that you are a mother or a father is a big part of how you experience your end of life, and what weighs on you and what is most kind of central to your experiences. And that's what we see all the time, and that's certainly what the fathers reported here. All right, so remember when we said, or when a few slides ago presented, that most of the fathers felt like that they were told by the physicians that they and their wives were told that their wives were going to die. So with that in mind, we asked the question, did your wife and your children have a chance to say goodbye to each other? And knowing that the vast majority knew that they were dying, there would presumably be that opportunity to have that discussion. But as you see there, over a third of the fathers said that that was not true at all, signaling that they had no such discussions. And when you add in those that said that was a little bit true, that they said goodbye, you have almost 60% of fathers reporting that their children and their wives did not say goodbye to each other, even though in most of those cases it was known that their wives were going to die. And that's, that carries significance not just at the end of life, but carries significance beyond. We certainly heard from the men in our group several stories about their children not feeling like they were involved or given the opportunity to say goodbye, or kept in the dark about their mother's health. And that's borne out here in the research. And in our opinion, that 60% represents a lot of lost opportunity to have meaningful conversations, and really kind of underscores some of the improvement that we can attain. You see here the number of patients who reported that, or fathers who reported their wives were involved in hospices, about 2/3, which is a good bit above the national norm. So in some way that's encouraging, and you see in these next few slides the impact of that. So depending on whether or not their wives were in hospice or not, we asked them, did they feel like their wives were at peace with dying? And as you see there, compared to those who were not in hospice, those who were more likely to report that their wives were in fact at peace with dying. Similar here, this is a little bit different, but about prognostic clarity and saying goodbye to their children. Those who felt like they had been told clearly by the doctors and clearly understood what was going on, and that their wife's lifespan was limited, were more likely to kind of initiate that conversation than if that prognostic clarity was not there. Then kind of back to the hospice use again, you see what you see there. So those who were in hospice were about almost twice as likely to have that goodbye conversation than those who were not. And that really, again, kind of underscores the potential for having, I guess, the benefits of hospice, but also that there's some recognition that someone there is taking care of you, and that these conversations are not just kind of left to not happen. You see there another list of what we asked the fathers, what's the most important topics to have conversations with as their wives were dying. You see there the top one is raising children in the ways that reflect her wishes, values, and hopes. And we can certainly say from the men in our support groups that the pressure, the implicit or self-inflicted pressure to raise their children in the way that their wives would have wanted, was certainly something these men felt. and the ones who had conversations beforehand about this with their wives, would tell us that they felt better about doing that than those who did not. So I want to leave some time for questions. We'll kind of get to the end, but kind of what have we learned from these bereaved fathers? We've learned a few things. I think there's a few main take-homes. I think the biggest one is that there's a lot of work that we can do with these parents at the end of life to facilitate communication between husband and wife or partner and partner, and to facilitate communication between them and their children at that time at end of life, before the father passes away. And that's tricky. As clinicians, we know, and I'm sure many of you do too, those are difficult conversations to initiate. There's difficult conversations to bring up. There usually needs to be some kind of acknowledgement of the poor prognosis. So there's lots of obstacles that get in the way of having those important conversations. But we've learned from our clinical work with these fathers that what happens in those weeks and those months, or maybe even longer, when we're looking at an end-of-life situation, is not only impactful during that time, but carries on forward in the months and weeks and years and maybe even decades after that. And so we're really not serving these parents and these families as well as we could if we don't help them to think about what conversations to have and help them have those conversations in a way that's going to be beneficial for them then and beneficial for their families moving forward. Let's get to that. So real quick, what's next? Well, we have, Don alluded to, we've expanded our interest and expanded our website. So we're now not just looking for fathers who have lost a wife or a partner to cancer, but we're looking at any parent who has lost a co-parent and is raising children at the home, regardless if they're mothers or fathers. And so we've created this new website, widowedparentorg, that in some ways is similar to the former one, but has that expanded focus. And we have lots of great resources, and also have a new survey here. And this is what we're hoping to learn, what we've learned from the father survey, we're hoping to learn more about with mothers and for those who didn't just lose their spouse to cancer. All right, I think that's, there's our team, which we don't need to go over all them, but this is certainly not, Don and I are the ones presenting, but it's certainly been a team effort and continues to be. I'll let you go from there. Okay.
All right, guys, that's amazing work. Thank you both so much for.
Thank you.
I've got several questions, but you're not here to answer my questions. You're here to answer our audience's questions. So if you didn't already do so at the beginning, please text to the number 22333, the letters UNCCN to join. If you already did this at the beginning, you're good to go. Please go ahead. For our audience, we'd like you to go ahead and start sharing your questions with us as soon as possible, so that Dr. Rosenstein and Dr. Yopp can answer those. Looks like we had one come in from the poll earlier. So you did get that right from the poll, and please go ahead and share your questions. I've got several.
Can I just jump in and make,
please.
let me mention a couple of things while we're waiting for some questions that we may not have made perfectly clear. Mm-hmm. Number one is the group for widowed fathers is ongoing. So if you know of people who you think might be able to get to the Triangle area, we're here in Chapel Hill, you can reach out to us. The second is, in just a few weeks, we're going to be starting the first Widowed Mothers group, and so there's room in there. And the third is escaping me. There was something else I wanted to mention about this, and I can't remember.
We can come back to it. All right. So first question, is there training going on for MDs to learn how to stop trying to treatment on patients? Mm-hmm.
Yeah, sure. So the short answer is yes, but these are cultural shifts that are not easy to do. I think that compared to when I trained in medicine in the 1980s, it's been a dramatically different set of conversations, more candid conversations about kind of the option of not pursuing active treatment. But I do think that there's still a lot of room to go. I think that at UNC and a lot of other places, the palliative care services are strong and getting stronger, and I think that conversations like this are part of the curriculum for kind of all kind of physicians training. But it's it's not easy work, right? And these things are not easy to do. And so a lot of physicians who are deeply kind of involved in trying to cure cancer kind of find it difficult from time to time to shift ground. But the answer is yes, but there's more work to be done.
Very good. So how do you plan to get this process started early enough so that patients and families have time to start the process? I'm assuming the farewell, the grieving.
Yeah, that's a great question, and we've had one too many examples of it being too late when it's recognized that those conversations need to have. And I think it's really important for psychosocial support staff like myself and others to really be working with the medical team, and when they have, we have a lot of patients here at UNC, but when they have a patient who is a parent and feel like some of these conversations need to be happening, to let us know about these patients early and then to build a relationship. It's much better I'll speak for me personally, much better to have these conversations if I have a relationship with the family and if we have time to kind of bring in the kids, and if it's not rushed and if it's not last minute. The other key part is that patients need to be told their prognosis. It's hard to think about planning for something if you don't have that impetus to start planning for it. And I think for the most part, the physicians are wonderful at delicately sharing challenging news. And sometimes people want to hear that news, sometimes people do not, and that's part of our challenge too. But the key point of starting early is exactly right.
So the next question asks about what are our priority projects for the book's profits. Well, we haven't seen any yet, but if we get any and they go back into when they go back into the program, I can tell you that the two questions that we get asked most commonly after we talk about this is, what about widowed moms, and is there something different about cancer as opposed to other sources of death? And as Justin mentioned, we're now attending to both widowed moms and widowed dads, and we're interested in people who lose a co-parent for any reason, including motor vehicle accidents and suicide and so on. So I guess the top priority is going to be to expand this program to widowed parents more broadly, making sure that our website has got up-to-date resources for people, trying to, now that we're starting our second support group, for widowed moms, we want to be able to expand that. If there are, if there's interest in your own centers in starting a program like that, we're happy to talk with you. I can't promise what kind of financial support there could be. It doesn't cost a lot of money. We basically feed people and we get volunteer sitters so that the widowed parent doesn't have to skip it because they don't have childcare. So we may have more priorities. We haven't talked about it yet because we haven't seen any profits. So we'll see. We'll see how that goes. You want to do the next one?
Yeah, so there's one about the Kids Camp program, which we did mention, but is a phenomenal program started by a foundation by a couple of ex-NC State football players that we've had the opportunity to meet, Tori and Terrence Holt, and their mother passed away from cancer when they were high school, college age. And they have a great program, Kids Can, as the question shows there, at Rex and Raleigh, Duke, and over at Alamance Regional. And that really is, I've suggested all the time to these families, and it's a family-based support program for parents and their children, parents who have cancer and their children. I think it meets once a month, and parents go and the parents break off into their own kind of support group, support conversation, and the children are kind of divvied up according to age. And I think they mostly keep the focus on having fun, and they sprinkle in some real conversation and some general cancer education. But I think the best thing that offers is for kids to see that there are other kids going through this too, and it maybe kind of trigger some conversations in those groups that can then go to home. But yeah, that's a great program, Kids Can.
Just two other things to mention about other programs. Camp Kessam is a camp that goes on in the summer for kids who have kind of lost a parent, and so KESSEM.
One S,
KESEM, Camp Kessam. And then we also just learned of a very cool not-for-profit organization south of Boston called Empower Her. That's all one word. You can find their website. And what they do is they have a mentoring program for girls who lost their moms and they also do special events, and they're thinking about expanding to other places, and they're thinking about expanding to programs for boys as well. But I'm looking at the clock, and we have a few more questions. So do we have any idea, or can we elaborate on what improved symptom management looks like in end-of-life care? Yeah, it's a long conversation, obviously. I can start and see what Justin thinks. But if any of you who are listening have not yet read what I think is a groundbreaking study by UNC's Ethan Bosch, this was work that he did at Memorial Sloan Kettering a few years ago, but they just had a publication last year on the use of patient-reported outcomes, PROs. And what they showed, in addition to improving kind of symptom burden and quality of life, is they demonstrated a survival benefit of about 5 months, which is kind of better than a lot of drugs that are approved, for people who were living with advanced cancer by virtue of asking in a systematic way patients to fill out patient-reported outcome forms and then having some system in place to manage that. And so I think that the short answer to this question is what it looks like is systematic screening of patients in active treatment or at the end of life to ask them kind of about their pain, about their breathing, about their bowel and urinary habits, about their mood symptoms, and then having some kind of clinical service in place to respond to those needs. But I think that what Bosch's work and others has shown that we miss about half of the symptom burden by not asking people systematically. So that would be my main answer to that question, is the use of kind of systematic patient-reported outcomes coupled with a clinical service to respond to it. I'll just keep going with the palliative care program at UNC. This is a program that's run by Laura Hansen and Gary Winselberg. There's now a fellowship program, and they've got 3 fellows, and essentially it is mostly an inpatient palliative care program, consultation program, and but they also have an outpatient clinic in the cancer hospital, a symptom management clinic, and they are focused not just on end-of-life care, not just on hospice care, although that's a big part of what they do, but trying to shift the attention to physical symptom management and emotional symptom management much earlier in the process. And I think that what we're all witnessing in medicine over the last 10 or 15 years is to stop thinking about palliative care as simply end-of-life care, but recognizing that there's nothing inconsistent about palliative care, which really just means active recognition of and response to physical and psychological symptoms and trying to have active symptom reduction interventions. There's nothing inconsistent about palliative care and curative intent as well, so that it doesn't mean that you've got to wait until our kind of cancer-directed treatments are no longer effective to then call in the palliative care folks. It looks like it's the end of the hour.
It is. I'm going to try and squeeze in one more question, if I may, and we can go just a couple minutes over if you'll bear with us. But from a technologist standpoint, are you seeing ways that people are using technology, either grieving widowers or children, to maintain relationships once you've worked to establish them? And I know I've seen this with other chronically ill patients through some treatments where, in this case, it was adolescents, and where they maintained some bonds through social media, through other technologies that they continue to maintain years later, that really seem to have played a fundamental role for them.
So we've seen some of that, and there's probably a lot more going on that we don't know about. I mean, there are lots of private Facebook groups and other things. One of the things that has blown me away since we've been doing this work is I've tapped into some of the international bereavement and grief initiatives. And in the United Kingdom, for example, there are lots of different groups that have kind of very active Twitter kind of feeds and kind of Facebook programs and so on. So I think that there's no question, especially with geographic kind of separation, that this is a great opportunity. But I don't know if you...
Yeah, and I think when Sheryl Sandberg wrote her book Option B last year and started a whole Facebook community, that's, I think, taken off pretty well. And there's a lot of different kind of specific Facebook groups that they have based on whether you're coping with loss, whether you're struggling with a chronic illness. And I kind of follow a couple of those, and they seem very active. I don't know if there's any data to support that that's helpful or that, but it's certainly available for people if they're interested.
Good. Well, guys, thank you so much. I've just got a couple of things to wrap up with. We want to thank the North Carolina General Assembly for their generous support of the UNC Lineberger Comprehensive Cancer Center and the UCRF, the University Cancer Research Fund. Specifically, we want to thank Mary King, Veneranda Obore, and John Powell for all the hard work they do for this and every one of our lectures. Coming up, we've got March 16th, our community lunch and learn, colorectal cancer, what you need to know with Tammy Triglianos. That's this Friday. Then on March 28th, we have a medical and surgical oncology lecture, meeting the unique needs of the pediatric oncology patients with Dr. Thomas Alexander. And then we've got an April 11th RN and Allied Health lecture, and that's identifying patients at risk of malnutrition with Meredith Moyers. So lots of good stuff coming up. I'll mention that starting April 11th, we'll be using Zoom, and we'll send out lots more information. Anyone who's using WebEx or using GoToWebinar today, we'll be switching to Zoom in April. I think you'll like it even better, and we'll have plenty of information to support you on that. For the folks using video conferencing systems, using MediaSite, everything's the same. You can find out about all of our events at unccn.org/events. 919-445-1000. Questions, comments, visit our site, Twitter, Facebook, YouTube, you name it. All right, gentlemen, thank you both so much.
Thanks so much.